Hello, my name is Courtney White. I am the Senior Director of Patient Outreach at the American Thoracic Society, the ATS. Welcome to this webinar today. It's on pulmonary vascular diseases, right? It's entitled Pulmonary Hypertension and Scleroderma MYTHBUSTERS. That's PAH Scleroderma MYTHBUSTERS and PH MYTHBUSTERS. This is brought to you as part of the Lung Disease Week at the ATS program, which is designed to foster information exchange between patients, patient advocates, and scientific and clinical experts. So we'll be holding a number of these events throughout the year at the ATS. We have upcoming events of this type on lung transplant, scarring and fibrosis. We're going to do one on caregiving and caregivers and critical care and hospitalization and a few others. So please check back with us if you're interested in any of those topics. The webinar today is designed to be a roundtable format as opposed to the standard presentation with slides. And so we hope that it'll be a little bit interactive. You can ask questions of the Dr. Mathai and of the panelists. Type the question into the chat box and send that to me and we'll share the question. Some of you have previously sent me questions by email. Just as an FYI, the information that's presented here today is designed for educational purposes only, and it is not intended as a substitute for direct medical care from your provider. So please contact your primary care provider or your specialist if you have questions related to your specific diagnosis and treatment. Now, with that said, it's my great pleasure to introduce my two esteemed colleagues who are members of the ATS Public Advisory Roundtable, which is the patient perspective arm of the ATS. Ms. Marie Mesquier-Rand of the PH-Aware Global Association and Ms. Carrie Connolly of the Scleroderma Foundation. I'll ask Marie to introduce herself and then Carrie, and then we'll ask you to introduce Dr. Steve Mathai.
Hi, I'm Marie Mesquier-Rand. I am the Managing Director of PH-Aware Global Association. We are an advocacy group that represents the pulmonary hypertension community. And we do two major things, which are global outreach, and we develop technology for research. And we are grateful for everyone who decided to join us today.
Carrie?
Welcome, everybody. Thank you for joining us today. As Courtney mentioned, my name is Carrie Conley. I'm the Director of Programs and Services at the National Office of the Scleroderma Foundation. We're located just 20 miles north of Boston. However, we have a network of chapters and support groups throughout the country. The Scleroderma Foundation is a leading advocacy group for those living with scleroderma and their families. We have a threefold mission of support, education, and research. We assist patients and their families cope with scleroderma through mutual support programs, peer counseling, physician referrals, and educational information. We promote public awareness and education through patient and health professional seminars, literature, and publicity campaigns. We also are a leader in stimulating research to improve treatment and ultimately find the cause and cure of scleroderma and related diseases. We're very grateful to be part of the discussion today.
All right, thank you, Carrie and Marie. I don't have Dr. Mathai's bio, so I'm going to ask one of you if you just give us a nice little introduction for our Dr. Mathai. That would be.
Steve, thank you for being here today. Dr. Stephen Mathai from Johns Hopkins University, who I've now known for quite a number of years, PH specialist and with an expertise in scleroderma, which is why we're grateful that you're here today. And I couldn't even begin to list your pedigree of all of the things that you have done and the research you've worked on. So I'm just going to say thank you for being here, and maybe you could say a little bit about yourself for us.
Sure. Well, thank you for inviting me. I'm very happy to participate in this program. As Marie alluded to, I am a pulmonologist at Johns Hopkins, part of the Pulmonary Hypertension program at this institution. And I have a clinical and research focus on at-risk cohorts, in particular patients with scleroderma who are at risk of developing pulmonary hypertension. So we have numerous research and clinical programs to evaluate, treat, and hopefully improve outcomes for patients who suffer from both these diseases.
So thank you, Dr. Mathai, and that actually is sort of a great segue. You know, before we get into the meat of the matter, Carrie and Marie has some really great MythBuster questions that they'd like for you to weigh in on. But as a general sort of 30,000-foot question, in terms of pathogenesis, and as with a number of other pulmonary conditions, does socioeconomic status play a role in mortality rates and other negative clinical outcomes for PAH patients?
There's not as much research in PAH and socioeconomic status as we would like at this point. I think because PAH in particular is a rare disease that requires significant expertise in terms of properly diagnosing the disease, that sometimes makes it difficult to study questions such as those you raised regarding socioeconomic status. As far as I'm aware, there are 2 or 3 publications that have looked at this using large database analyses of patients who have underlying pulmonary hypertension, but whether or not they have pulmonary arterial hypertension is unknown due to the specificity of that particular diagnosis and whether or not these databases are able to capture that. There is a relationship between socioeconomic status and time to diagnosis. So there may be delays in diagnosis based upon socioeconomic status based on these large databases that I'm talking about. But in terms of outcomes, I'm not sure we know as much about the specific outcomes in pulmonary arterial hypertension.
Excellent, and thank you very much for that answer. So what we're going to do, we're going to ask Marie and Carrie to alternate questions from the pulmonary hypertension side and the scleroderma PAH side, and then we have some questions that were sent in to us by the audience prior, and the audience members who are on this call, feel free to send your questions in right now as well. And Carrie and Marie, also feel free to weigh in with your comments with Dr. Mathai as well. So we'll go first, Marie. And Marie, do you have a question from the PH side?
See, we did a little true or falses. PH and PAH are the same thing, and if there's a difference, can you please explain the difference?
Sure. So there definitely is a difference, although pulmonary hypertension encompasses PAH. Not all pulmonary hypertension is PAH. So if you're thinking about circles, pulmonary hypertension is the big circle, and pulmonary arterial hypertension is a small subset of pulmonary hypertension. And in fact, it is a very rare form of pulmonary hypertension. If you look at pulmonary hypertension in general, there may be up to 70 or 80 million people in the US who actually suffer from some form of pulmonary hypertension. But thinking about pulmonary arterial hypertension, we're looking at a much smaller number. The incidence of the disease is probably around 2 to 4 per million in the US, which puts the number at about 40 to 60,000 patients. So orders of magnitude difference in terms of the prevalence of pulmonary arterial hypertension versus pulmonary hypertension.
Excellent. So Marie, that myth is busted. PH and PAH are not the same thing because one is a subset of the other. So our first myth is busted. We're off to a roar. All right, Carrie, we're going to switch to you on the scleroderma side. On the PAH side, do you have a question for Dr. Mathai?
Yes. True or false? You are what you eat. Can a patient's monitoring of their diet offer any better health outcomes? We have heard that reducing a low sodium diet can assist. Anything else that you could offer?
That's a very good question. I do think that diet has a role in overall health. We have little data that supports specific interventions to your diet that improve outcomes in PAH. But what we have observed are things like there may be an association between your iron levels and disease severity in PAH. So making sure that your iron levels are in appropriate range, even without anemia. If you have anemia, obviously that's one story, one thing that we're concerned about, but even having low iron levels may have an impact on outcomes in PAH, so that's something that's important to address. In terms of nutrition, obviously, making sure that your diet is well-rounded and does not have an excess of carbohydrates or sweets, which can impact regulation of blood sugar. Anytime diabetes gets involved in your overall health, that can cause problems for the heart and the lungs and your kidneys, and those are organs that are also affected by pulmonary hypertension and by scleroderma. So I think salt is a key thing when we think about for pulmonary hypertension. But other things that can exacerbate, specific to scleroderma patients, for instance, that could exacerbate your reflux, indigestion. So making sure that you're managing and aggressively treating your gastroesophageal reflux, GERD, is very important, because one of the consequences of GERD can be damage to your lungs. So that ensuring that you are being aggressive about monitoring your diet to avoid foods that exacerbate reflux is one way that a scleroderma patient in particular can help him or herself.
Excellent. So then that is not a myth. So there is some benefits from, of course, watching your diet and watching your sodium intake. And so we're going to go that you should probably, as a matter of best practices, always be aware of what you put into your body anyway, in terms of what you eat. All right, let's get a question from the audience. This is not a true-false question. This one is from Sarah, and Sarah says, what are the earliest signs and symptoms of pulmonary hypertension in patients with limited scleroderma?
There's not just one answer to that. I think it can vary from patient to patient, and one of the things that makes it difficult to diagnose without proper screening. So one of the things that all patients with scleroderma should ensure to be advocates for themselves is to make sure that they are undergoing yearly screening for pulmonary hypertension and for interstitial lung disease. So there are recommendations from the American College of Rheumatology and from the pulmonary hypertension organizations that patients with underlying scleroderma should have yearly screening. Now, the screening methods for pulmonary hypertension in scleroderma vary, the recommendations vary, but in general, they're based upon echocardiography, pulmonary function tests, maybe some blood work, but important to that is also symptoms. So if you have symptoms of either shortness of breath, symptoms of some functional limitations, you feel like you're unable to do what you were previously able to do, whether that's related to shortness of breath or fatigue or weakness, those are potential signs of developing pulmonary hypertension. Other things you may notice are things like swelling in your legs, which sometimes can be related to pulmonary hypertension affecting how your heart functions. And I think things like that are key things for you as a patient to recognize to recognize within yourself. If something has changed, you feel more weak, you're more tired, you have problems with your breathing, you have some swelling in your legs, those things should all be discussed with your providers, and to make sure that there are no exam findings that are suggestive of pulmonary hypertension or study findings that would suggest that, such as changes in your echocardiogram or pulmonary function tests.
Thank you. Excellent. All right, so we're going to go back to the myths. And Marie, do you have another myth to be busted or affirmed?
Well, yes. The next one on our list, you just kind of answered, but I'll ask it again just to see if. So here's the question, Steve. True or false? PAH can be diagnosed with an EKG or an echocardiogram.
So this is a very important question because it's something that comes up often. Pulmonary hypertension cannot be diagnosed with an echocardiogram, nor with an EKG. So pulmonary hypertension can be suggested by an echocardiogram. An echocardiogram is an ultrasound of the heart, and when an ultrasound is performed on the heart, you can get an estimate of the pressure inside the heart that may reflect the pressure inside the lungs. What that pressure estimate does not tell us is what are the contributors to that elevated pressure, number one. Number two, multiple studies have demonstrated that when you compare directly that estimate of pressures in the lungs to directly measured pressures during right heart catheterization, which is a direct measurement, there's a lot of variability. They don't necessarily line up. 30% of the time, they're within 10 millimeters of mercury pressure difference. And 30% of the time, they're more than 10 millimeters of mercury percent difference or measurement difference. So I think it's it's a concern to rely upon echocardiogram as a diagnostic tool. It is a screening tool, and if it's abnormal, it should lead to a right heart catheterization to formally diagnose and also understand the severity of pulmonary hypertension at that time.
That is an excellent myth that needed to be busted. So thank you for that, Marie. So the EKG and ECG echocardiograms give estimates, but should not be relied on as the tool they're diagnostic. So let's switch to the scleroderma side. Carrie, do you have another question for Dr. Stephen?
We do. True or false? Excuse me. Is home health monitoring a good idea? Considering telehealth is here to stay, what is the best to monitor? Blood pressure, O2 stats, weight?
All the above. More data that you can routinely obtain at home and present to your providers is helpful. I think for both scleroderma patients and pulmonary hypertension patients, keeping track of those, perhaps having a log where you're checking it maybe every morning. If there are concerning symptoms you have, you notice with activity you might feel a little lightheaded or dizzy or have more shortness of breath, obtaining repeat measurements, particularly of your blood pressure and your saturation and maybe your heart rate, which many of the saturation monitors can obtain. You can obtain that as well. Those types of data are really helpful to a provider. And I agree with you completely that I think telemedicine is here to stay. And I think in many ways, it's an important advance for us to be able to monitor patients and to understand what's going on with them when they're at home. There are some limitations, obviously, with telemedicine, not being able to examine somebody directly. There's some information that can be lost over the video screen, but having objective data, blood pressure, heart rate, saturation, and weights is invaluable.
Excellent. So home health monitoring is always a good idea. The more data that you can capture to provide with to give to your providers, the better. Sasha is online with us. I'm going to take a question from Sasha. Sasha says, can scleroderma patients with PAH get sudden abrupt worsening of PAH despite being on appropriate PAH therapies? If so, what is the potential mechanism of this? Is it like scleroderma renal crisis?
It's a very interesting question. Sudden acute worsening of shortness of breath in the setting of someone who has underlying scleroderma and pulmonary hypertension raises a couple of possible causes. I think the first thing that would be concerning, that would be a life-threatening change, would be something like a blood clot in the lungs. Acute blood clots in the lungs or sudden blood clots in the lungs obstructing the blood vessels in the lungs, you might imagine, would raise the pressure in the lungs and put strain on the heart. So that is something that could definitely account for that. I would not expect that to go away. So if you develop those symptoms and they're gone in a couple of minutes, that probably is not your issue. But obviously, if you have sudden shortness of breath in the setting of pulmonary hypertension that persists for more than a couple of minutes, that's something that needs immediate medical attention. One of the things that can happen, I think you were being specific in your question to make sure that you weren't including this, but if you were to miss a dose of medications, okay, there can be a rebound phenomenon. So it's very important, if you're taking medications that are either once a day, twice a day, or 3 times a day, that you adhere to that schedule, because missing a dose of these medications in select cases can lead to sudden worsening of pressures in your lungs and the same outcome of increased shortness of breath occurring somewhat suddenly can happen. Beyond those 2 scenarios, I don't know that there's really an acute or sudden worsening of shortness of breath that I would expect that would be related to pulmonary hypertension. There can be other conditions, exacerbations of underlying lung problems that could lead to more shortness of breath that don't necessarily have specific origins in pulmonary hypertension. And that list is very long.
Excellent. Thank you so much, Doc. All right, we're going to pivot to Marie for another myth to be busted or affirmed. Marie?
So having traveled this journey for quite a while in speaking with doctors, true or false, Steve, physicians want patients to come prepared with questions during either in-person or telemedicine visits. And can you please discuss the importance of the patient-physician communication and the perils of misleading information on the internet?
Well, I'm glad you just threw me that softball question, Marie. It's really helpful. So I really would encourage patients to come to talk with their doctors with a list of questions in hand. It makes it very, it really makes it easier for us to understand what questions you have and to make sure that we're addressing them. Many times when I am meeting with a patient who does not have a list of questions, I'm telling that patient what I think he or she may not know. They may already know that. They may have a totally separate question that I have not addressed because I am not aware of their particular situation. And that's one of the things that I think helps the patient-physician relationship, is to understand what is most important to that patient. So if you come and say to me, you know, I really want to be able to do X. Can we do that with my condition? That helps me understand your goals, and understanding your goals helps me make a plan to get to those goals. Okay, without those questions, it's very hard for me to understand that, or any provider to understand that. The flip side to that is, as you alluded to in the second half of your question, was don't believe everything you read on the internet. So that can be problematic, and I think that there's a lot of misinformation out there on the internet that can either scare you or falsely reassure you. And I want to make sure that if there are things that you are reading on the internet that you have questions about, that is another source of questions that you can have a communication with your provider about. I think that's a really important thing, because you want to make sure that you and your provider are communicating from the same starting point.
And so a lot of that oftentimes will fall on the provider, because particularly for newly diagnosed patients, Marie, who have not yet come across a Marie or a Carrie who can give them some guidance as to what to do, where to get your information from in the wild, wild west out there. So sometimes they'll come in probably to your office, Dr. Bataille, and say, I have this that Google says is happening to me, and I know this is true. And then it's up to you to sort of debunk it, especially what we're doing right now. Some of that takes a little bit of time, I guess, away from getting to really what you need to get to do in those visits, I would think.
It can, but it's really important. And I think that you know, one of the things that is key when you're trying to develop a relationship with your provider is that you make sure that adequate time is allocated to you. Okay, so if there is one appointment and it's initial evaluation, I'm sure there are many questions that a patient may have, and it may make sense to say, okay, these are the top 3 questions I want to get answered today. And then ask the provider at the end of the session, saying, hey, you know, how can we, I have other questions. How can we connect again? Is this something we can communicate via email? Can we have a phone call? Can we have some other kind of follow-up, and make a plan in that regard? Because it can be overwhelming both to the patient and to the provider if someone comes in with a notebook of 30 questions, because you want to make sure that you get to the important things you want to address that day, but then also have a plan in place for addressing additional questions.
Absolutely. All right, so moving right along to Carrie, do you have a myth that we can tackle as we go through our list here?
Yes. True or false? Are there any new therapies on the horizon that excite you? If so, please explain.
Yes, I think that there are several advances in our understanding of the pathogenesis of both scleroderma and pulmonary arterial hypertension that offer opportunities for therapies to be effective. Now, the specifics of those therapies are probably beyond the scope of this forum. But in general, therapies that target the fibrotic process, the scarring process that occurs in the lungs and in the skin and in other organs in patients with scleroderma, we're hopeful that those therapies might be effective and safe. That's the other part of it. Things may work in an animal model of scleroderma or of pulmonary hypertension, but they don't work in humans. I can fix pulmonary hypertension in a mouse, okay? It's a lot harder to do that in a human. So I think that those types of therapies that are focused on the underlying pathogenesis. So for scleroderma, that's a fibrotic process that occurs in the skin and in the lungs and to some degree in the blood vessels. And in pulmonary hypertension, pulmonary arterial hypertension, it's a remodeling of the blood vessels in the lungs. So for reasons we don't fully understand, the cells that line the blood vessels in the lungs grow uncontrollably, and that causes narrowing of the blood vessels in the lungs that raises the pressure in the lungs. Therapies to date have focused on dilating the blood vessels, which is effective to reduce the pressure, but doesn't address that primary process of uncontrolled cell growth on the lining of the blood vessels. And newer therapies that are being developed and tested now focus on that, trying to stop the remodeling of the blood vessel and do what's called reverse remodeling. Bring those cells back into check and then have them regress to allow the blood vessel to function more effectively. So I think we have a couple of different pathways that are being focused on and leveraged to identify therapies that might be effective for both scleroderma and for pulmonary hypertension.
So, as both Kerry and Marie can attest, hope springs eternal. And so whenever we hear you say, there's some pathways that we're looking into for X, Y, or Z, as a patient myself, that gives me a little bit of hope. And sometimes that gives you that extra oomph that says, all right, let me redouble my efforts to do what I need to do on my end of it. So I see Marie and Kerry kind of nodding their heads. So I know you guys hear this all the time. But with that said, Aaron has a myth for us to bust. Aaron, who's online with us, says, here's a myth to bust. Google tells me that the life expectancy is about 11 years with scleroderma. Is that accurate?
It kind of depends. Well, it depends on several factors, okay? So overall, that might be an average outcome, but for an individual person, there are many variables that go into life expectancy. The type of scleroderma you have, whether it's diffuse scleroderma or limited scleroderma, or even rarer forms of scleroderma, such as Scleroderma scleroderma. If you have interstitial lung disease or not, do you have renal disease or not? Do you have pulmonary hypertension or not? Do you have PAH? So all of those factors go into overall survival for patients with scleroderma. I think the real key thing, if you are someone who has been diagnosed with scleroderma, is making sure that you have someone who is a provider who is an expert in scleroderma. That is a key thing, because scleroderma is a whole body disease. Nearly every organ in the body can be affected by scleroderma, and someone who understands scleroderma is going to look for potential organ involvement, try to address it and treat it, and improve your overall health. And that's a key thing that sometimes is missed when people don't fully understand scleroderma.
Absolutely, the systemic nature of it. Let's take one more quick question from the audience. This is from Leroy. This was sent in prior. Are there studies to show that there's a link between being exposed to PVC dust and their products at work and the onset of scleroderma?
To my knowledge, there is no strong data to support that association. I think that there has been a lot of interest in whether or not scleroderma is a disease that is triggered by exposures. I think there's ongoing research looking at that. There are some interesting observational associations regarding risk factors for developing scleroderma. I think one of the most interesting is the fact that there is the Choctaw tribe in Oklahoma, I believe, has a very, very high incidence of scleroderma, and it is 15 to 20-fold higher than the general population, and we don't really understand why that is. And it could be an exposure, it could be genetics, it could be a combination of the two, or other factors of which we're unaware. So I think that there are risk factors that go beyond exposures. It's not just an exposure, it's probably genetics and multiple different exposures, and that predispose you to developing scleroderma.
Absolutely, that makes perfect sense. All right, we're going to pivot to Marie again for another PH Mythbuster question.
Okay, this is one of my passions, so I'm grateful that I get to ask this question, Steve. Is it important for patients to consider participating in clinical trials? If interested, should they ask their specialist about available trials? Please discuss.
Yeah, I appreciate that question. As someone who conducts clinical trials in scleroderma, PAH patients, and other populations of patients who have scleroderma and other forms of pulmonary hypertension, I think this is a key thing. You know, we're talking about two rare diseases, whether it's PAH or scleroderma, and the intersection of the two obviously is even more rare. And we want to understand best how to treat patients with medical therapies for these diseases. And that requires us to test our therapies. I think it is a very challenging situation for a patient to be in, to be diagnosed with a very significant medical problem, and then hearing from a provider that we have this therapy, we think it may work, we're not sure, do you want to participate? And I can only imagine how frightening that is and how challenging it is for a patient to understand that. But I think it is very important to ask and consider whether or not you as an individual feel like you can participate. I think we get our best knowledge from these types of trials. As I mentioned, I can give pulmonary hypertension to a mouse or a rat and I can fix it with interventions, with medications. When we try to do the same thing in humans, sometimes that doesn't work. And we need to understand then why is that? And what are the approaches we should take to potentially cure both pulmonary hypertension and scleroderma? Because it's really only going to come through investigation where we're going to be able to make those advances.
Excellent. So should the as a best practice, should the patient initiate the clinical trial conversation saying, hey, you know, I heard of this trial on clinicaltrial.gov, or somebody I know is in this trial? Or is it a situation where you as the provider say, you know what, we have done X, Y, and Z, perhaps you may be a good fit for this trial? That conversation is initiated by whom? Jim.
I think it should be on both ends. I think, for instance, when a patient comes in and you're having a discussion about treatment, it should be what's available and what, in terms of what therapies are currently available and approved by the FDA. And it should also include, are there clinical trials of newer therapies that you think might be appropriate for me? On the physician side, as you develop a longitudinal relationship with a patient, it may be that they're 6 months, a year, 2 years into therapy, and the availability of a clinical trial that focuses on patients who fulfill that particular criteria becomes available. That's when the provider should say, hey, we have this clinical trial, we're participating in it, maybe you would like to consider it. I do think clinicaltrials.gov is a great way for patients to keep up with all the potential therapies that are available in clinical trials, because even as a provider and someone who focuses on this, I can't keep up with all the individual studies. Now, there are pharmaceutical sponsored studies, industry-sponsored studies, of which, you know, there's a lot of more potential of publicity about, and maybe I hear about those more than I would hear about single or multi-center studies that are investigator-initiated studies that may be on a smaller scale, but yet be important for participation. So as an example, there was a recent clinical trial that was conducted at the NIH Clinical Center of aldactone, which is a diuretic. This particular medication, there was some suggestion that it might improve overall heart and lung function as it pertains to the pulmonary blood vessels. And there was good data to support that. And then in observational studies of patients with pulmonary hypertension, there seemed to be a signal that maybe it had some benefit, but you needed to do a clinical trial randomizing patients to placebo, sugar pill versus that medication. We weren't participating in that study, but because of where we are located in Baltimore, it's not too far of a drive to send patients down to the NIH Clinical Center to do a clinical trial. And I think that type of thing, for my patients who are stable on therapy, I would say, hey, why don't you consider this?
So Carrie and Marie, as a general rule, do you, as patient advocacy organizations, do you guys keep abreast of trials in your area? Do you sort of aggregate information that you get from different sources so that when patients come to you and say, I'm at my wit's end, do you provide direction from your organizations as well regarding trials?
I guess as the doctor had mentioned, clinicaltrial.gov is one that we definitely refer to. We also work with the Scleroderma Clinical Trials Consortia, which is also a great reference for our patients.
And we actually, on phaware.global's homepage, we actually have a clinical trial match tool, which we spent about a year working with medical professionals and CRO, clinical research organizations, and anybody we could get to help us refine the questions so that you match it. So it actually aggregates the information on clinicaltrials.gov and matches you more quickly to specific PH trials. So it's readily available for, we had that tool developed and it's on our website.
Excellent. So for the patients online, there are resources out there. The Scleroderma Foundation and the PH Aware Global Association have additional resources. All right, Carrie, we have another MythBuster question from the Scleroderma side from you.
Yes. So we know that approximately 10% of systemic sclerosis patients may develop PAH. We also know that many scleroderma patients may present symptoms differently and at different times. There is no predictable pattern. Do you find that most patients that you see already have the diagnosis of systemic sclerosis, or has it been in your experience that the PAH confirmatory diagnosis may lead to the identifier of scleroderma or systemic sclerosis?
That's a very interesting question, and it happens in both directions. So we are fortunate at Hopkins to have a very large scleroderma center that is a part of our referral base. We work closely with the Scleroderma Center. They have routine screening for pulmonary hypertension that they perform on all of their patients that are seen there. So many of my patients have already been diagnosed not only with scleroderma, but they've been screened appropriately for pulmonary hypertension and present to me in that state. The reverse also happens, where I will see a patient who's been referred to me for evaluation of pulmonary hypertension, and I establish the diagnosis of scleroderma. Sometimes that pulmonary hypertension component is key to establishing it, because as you alluded to, scleroderma is a disease that has many different features, and sometimes the classic features of scleroderma that are noted when you examine somebody or on blood tests are not present. So having key features like pulmonary hypertension, pulmonary arterial hypertension in particular, in the setting of someone who has other features of scleroderma can help establish the diagnosis in the absence of other more traditional markers such as antibody testing. So I think that in both directions that can occur, whereas someone comes to me with established diagnosis of scleroderma, but I would say probably 15 to 20 times a year I am diagnosing somebody with scleroderma.
Excellent. So that is affirmed, but it works both ways, from cystic sclerosis to pulmonary hypertension to PAH and the other way. So this question is, I can't see who sent this in, but should you have an annual right heart cath once diagnosed with PAH?
That is a tough question to answer. It is something that varies by provider, whether or not there's a need for routine right heart catheterization after stability has been established. So in general, if I'm taking from diagnosis to treatment to follow-up, obviously a right heart cath is mandatory to diagnose pulmonary hypertension, properly classify a patient with pulmonary hypertension, and understand the severity of disease. Those data obtained from that initial right heart catheterization will inform how we treat you, which medications are appropriate, and typically 3 to 4 months after that initial diagnostic catheterization, after therapy has been initiated, we will reassess you. Personally, in my practice, I don't do a right heart catheterization at that time. I will do an echocardiogram, a 6-minute walk test, some other blood work to see if there are trends towards improvement or obvious improvement in those parameters. At about 1 year, assuming the patient has done well, I might repeat a catheterization to make sure that what I am suspecting clinically, based upon what the patient's telling me, what my exam shows, and what these non-invasive tests like echocardiogram and 6-minute walk test, et cetera, what they show is confirmed by hemodynamic improvement. If there's no hemodynamic improvement, then we might change therapy again, and again follow that 3 to 4 month schedule of repeating those non-invasive tests. But once stability has been obtained, I personally don't believe there's a need for a yearly right heart catheterization. If something changes, symptoms change. There's something changing on your echocardiogram, something on your 6-minute walk test, then that might trigger another right heart catheterization. But a yearly right heart catheterization may not be indicated. Now, as I said, this is provider specific. So one provider might feel differently than another.
All right. This question is from Elise. It's a specific question. She says, I'm overdue for my annual PFT and echocardiogram at Johns Hopkins due to COVID. It is going on 2 years. When is it safe to get these done?
I would say it's safe to get it done. That's the question. Well, I think it's important for you to get those tests. Full disclosure, my wife runs the pulmonary function lab at Hopkins, and I know the procedures quite well there. We are requiring that you have a negative COVID test before you get your pulmonary function test, because pulmonary function tests are an aerosol generating procedure. So we want to keep everybody safe. But we will know before you come in for that test whether or not you are tested positive for COVID. So what we would do is try to schedule both the pulmonary function test and the echocardiogram on the same day, so you can have that COVID test, feel comfortable coming into the hospital. We are providing all of our providers with protective devices. We will ensure that the patients are wearing protective devices when they're doing these tests, try to minimize the risk. There is no way to minimize the risk to zero, but we are doing our best to keep people safe.
So Elise, you got to get your COVID test, and you may want to try to pull the Kevin Bacon 6 degrees of separation on a webinar with Dr. Mathai. His wife runs the program. See how far that gets you. Can't guarantee you any results, but give it a shot. All right. So we're bumping up towards the top of the hour. But I think this is a big question, and this one will go back to Marie. Is this a myth buster or just a general one, Marie?
It's a general question, and it relates to what we were just discussing, Steve. There are still some questions and concerns related to the COVID-19 vaccine in the community related to the speed of the development. There's some science, like 20 years of science that supports that, but I'm not sure everybody knows that. And can you offer some clarity today regarding the vaccine and recommendations?
Yeah, this is a really important topic, and I think something that I have been speaking about with my patients every clinic that I have, and I think it's really important for you to not only hear from me, but also from your personal providers who understand your situation better than I do. But in general, the recommendations, and this is based upon the American College of Rheumatology recommendations, which just came out a couple of days ago. So they had an advisory panel developed and convened to take the unique situation of patients with rheumatologic diseases into consideration when making recommendations regarding vaccination. And why it's unique if you're a scleroderma patient, if you are on immunosuppression. So if you're taking Cellcept or Myfortic, or the common medications that might be used, or if you're on prednisone or other medications like rituximab, any kind of immunosuppressive medication, there's some reasonable rationale to be concerned potentially about whether or not the vaccine would be as effective, or whether there are concerns that might be specific to those types of patients who are on these medications. So this panel was convened, and their recommendations are that patients who have underlying rheumatologic diseases, including scleroderma, should receive vaccine. And it does not matter whether it's the mRNA vaccine, the Moderna or Pfizer vaccine, or whether it's the J&J vaccine. There are no particular increased risks that they felt as a panel, as a community, that would be conferred upon patients with underlying rheumatologic diseases who are receiving a vaccine. Now, the one caveat to that is a little bit of the timing. So the timing of the vaccine may differ in terms of when you should get it in relationship to your immunosuppression, specifically if you're getting rituximab. Okay, so some patients with scleroderma for indications may be getting rituximab. That's a specific question that should be discussed with your provider. But the American College of Rheumatology recommends it. So I think that's one thing from the scleroderma side of things, which I think is a little bit different than PAH, because most patients with PAH are not on immunosuppressive therapy. From PAH world, we are advocating, again, that everybody gets vaccinated. And I think that the concerns are valid. This seems like this has been a short timeline to develop a vaccine. But as Marie mentioned, there's 20 years of science behind this, behind the methodology that has been used in the mRNA vaccines, for example, that's being applied now. We didn't have a really good target before. This target lends itself, the target being coronavirus, COVID-19, this target lends itself to this approach. Again, I mentioned there's no way to minimize risk to zero. There's no way to ensure that everyone's going to tolerate the vaccine without any side effects, because that's not reality. But the risks of the vaccine are significantly less than the benefits to prevent COVID-19 in you or your loved ones. And I think particularly as a patient with scleroderma and pulmonary hypertension, these patients, you are at most risk of having a really hard time if you were to contract this virus.
So, Dr. Mathai, dumb this down for me slightly, a little bit more, because we get this question, this COVID question everywhere, right? Everybody gets it. We get it a lot at ATS. I get it a lot from people who knows I work with, pulmonologists such as yourself. But talk a little bit about just the logistics of doing a trial such as this. Is it not true that when you have a vast amount of resources that are trained on an effort such as this, it makes sense that it would drastically cut the amount of time from to development of these therapies? Is it not true that because good governments are able to direct a lot of resources at this, and scientists are able to cushion a lot of time to do this work, that is part of the reasons why we have these vaccines developed so quickly?
I think that those are great points, and I think that is definitely the major driver is collaborations between industry and government, including not only funds and financial support, but also amongst researchers. So people who've often worked in silos trying to make their own vaccine, their own breakthrough, as it were, scientifically, have collaborated to say, this is what I learned from my experiments. This is what I learned from my experiments. Let's put them together and see if we can advance the field together. And I think this pandemic has really allowed for a lot of collaboration that may not have been present before, or been as willing to collaborate. And I think that has allowed us to move the field forward more quickly. Now, as an aside, I wish not that we had an issue like this to address, but this tells me that we have the opportunity as a community to focus on scleroderma or focus on pulmonary hypertension, and perhaps make huge advances in that way as well. So I do learn from this and hope that we as a community can collaborate more effectively to cure these diseases.
Yeah, I've been saying it myself. So, we can actually do it, can't we? I mean, why not? All right, very much. Thank you so very much. I really appreciate explanation. There are a lot of folks out there who really needs the talking points and the bullet points and the elevator pitches, because we have to condense some of these explanations down to folks who probably are really mired in or dug into their perceptions of these therapies or vaccines in general, or the politicization of whatever, and so forth. All right, so let's switch to Kerry. And do you have a final question for Dr. Mathai?
True or false? I have seen several mentions about the right side of the heart being able to heal itself over time. Is this true? Please explain, or false.
So, true with an asterisk. So, the right heart has a remarkable ability to recover if the pressures in the lungs are reduced. So, if you think about what pulmonary hypertension is and how the heart and the lungs are connected. So, blood is collected in your veins that has low oxygen content. That blood goes to the right side of your heart. The right side of your heart is responsible for pumping that blood into the lungs. The blood picks up oxygen in the lungs, goes to the left side of the heart. The left side of your heart pumps your blood out to the rest of your body through your arteries. Okay. Pulmonary hypertension is high blood pressure in the lungs. When pressures in the lungs rise, it puts strain on the right ventricle. Okay. The right ventricle, unlike the left ventricle, and the left ventricle, when we were designed, he or she knew that we were going to eat too much salt, gain weight, and develop regular hypertension. That's a known thing. So the left ventricle was designed to get bigger and thicker and overcome that resistance that occurs with regular high blood pressure. The right ventricle was not designed to do that. So it can only get bigger and stronger to a certain degree. So if we are able to reduce the pressures in the lungs, reduce the load on the right ventricle, the resistance against which it has to squeeze, to contract, then the right ventricle can get better. The extreme case of this is lung transplantation. So if someone has pulmonary hypertension, they may be a candidate for lung transplantation, and it is something that all you have to do is look at the x-ray of a patient. So the x-ray the day before they have a lung transplant, their heart looks this big. 3 days after the lung transplant, their heart is normal in size. And this is all the right heart that is causing the shadow of the heart to be big on the x-ray. The right heart, unlike the left heart, has a real ability to improve. The key thing is to get the pressures down, reduce the load on the right ventricle, and the right heart many times will improve.
All right, so that's pretty interesting. That's sort of partially busted there in terms of the right heart being able to heal itself. So again, we're bumping up against the top of the hour, and I'm probably going to take one more question so that we can graciously give Dr. Mathai a little bit of his time back. And so this question was sent in prior, and it says, what sleep treatments are there for a person who has several immune disorders such as scleroderma, Raynaud's, or PAH?
So to help to facilitate falling asleep and staying asleep, to improve sleep, that is a tough question. Because while there are many medications that can help someone fall asleep or even stay asleep, many of those medications were meant for short-term use and not for long-term use, A. And B, many of those medications, while they may physically allow someone to remain in bed with their eyes closed and feel like they're asleep, it actually decreases the quality of that sleep. So the most restorative phase of sleep is REM sleep. During that phase, your body is most relaxed. That phase of sleep, unfortunately, as we get more mature, that time we spend in REM sleep decreases, which is why as you get older, you start waking up at 4 in the morning, and you don't have the same kind of biological clock. Your biological clock changes. But as an aside, I mean, to this point, those medications that can help you fall asleep often further diminish the time you spend in REM sleep. So the restorative sleep is affected by that. So if someone is having a hard time sleeping, it's important to focus on, is there a sleep issue? Is there sleep disordered breathing, whether that's sleep apnea, central sleep apnea, restless leg syndrome, periodic leg movement disorder? There's all of these potential causes of poor sleep that need a medical professional to evaluate.
Yes.
Sleep hygiene is the other thing. Are you going to bed, watching TV for 3 hours, and then saying, why can't I fall asleep? That's not good sleep hygiene. Okay. If you wake up in the middle of the night, are you laying in bed for an hour saying, why can't I fall asleep? That's not good sleep hygiene. The recommendation there is to get out of bed, go and sit in a chair, and maybe read a book, see if you can make yourself tired so you can go to sleep. Those types of sleep hygiene things can be helpful to be addressed with your primary provider. So I think getting an evaluation rather than trying to take medication would be the first step.
I think that's excellent advice, some of which I need to take myself. I do have some sleep issues, and actually just saw my pulmonologist recently who told me the same thing you just said, which is make sure you have proper sleep hygiene, environmental scan, and see what you're doing prior to going to bed, and do you have the TV on, and do you have any sort of light being emitted, and basic things like that can actually help.
Yes.
So thank you very much.
This is your worst friend.
Oh, and the phone, yes, and the phone, of
Don't
course, yeah. I can't help myself. I'm plugged to it. All right, so this is great. Thank you so much. So what have we learned today? pH and PAH are two different things. So that myth is busted. One is a subset of the other. You are what you eat. You should monitor your diet to have better health outcomes. PAH cannot generally is not diagnosed with an EKG or an echocardiogram. Home health monitoring is always a good idea. When you visit your physician, try to be as prepared as possible in terms of the questions that you have for your provider. There are new therapies on the horizon, new pathways that are being explored. So pretty exciting. Patients should consider participating in clinical trials. If you have questions and need additional help with resources, touch base with the folks at the Scleroderma Foundation, or touch base with the folks at PH-Aware Global Association, or talk to your therapist. In terms of confirmatory diagnosis, cystic sclerosis to PAH and PAH to the cystic sclerosis can work both ways. And in terms of the right side of the heart being able to heal itself, that's sort of true. And COVID, the 100-pound gorilla, it's there. 20 years of science, a lot of resources put towards this. So those are the takeaways. So I just want to ask Carrie if you have any parting thoughts for the audience today before we go.
Well, this was really great fun. What a cool format. Thank you to the American Thoracic Society Public Advisory Roundtable, Dr. Mathai, for offering so much generosity of your time today to be with us. And of course, with PH-Aware, it was great to collaborate with all of you.
And Marie, parting thoughts for the audience today.
I feel exactly the same. And I think that some really interesting and important messages were sent, but I would like to say to every patient who's ever reached out to us, doctors are really human beings, and they really do want to hear from you, and those questions and being able to open that communication is so important, because that's where you're going to get your best answers, and they can't mind read. They don't know what you're what you're thinking about. And so I wanted to thank you, Steve, for being willing to come here and do this today. And thank you, Carrie, who I see is wearing her PH-aware pin in my honor. And thank you, Courtney and ATS, as always, for making wonderful things like this happen.
Thank you so much. And Dr. Mathai will give you the second to last word.
Well, I'd like to thank you all for inviting me to participate today. It really was a great forum, and I hope some of your questions were answered. And please do, as Marie and Carrie have said, and Courtney, please do talk with your providers and be as open as you can. It can only help. And I think that's the way forward for us as providers, to develop good relationships with our patients.
Well, thank you guys so very much. For the folks on the line today, this webinar was recorded. We'll have the recording up online at the ATS within a few days. We'll share that with our partners at the Scleroderma Foundation and at PH-Aware, so that you can share this with the folks who weren't able to come, or you can go back and listen to it at your leisure. Thank you again. If your question wasn't answered, we'll forward it on to Carrie and to Marie. And thank you all on behalf of ATS. Have a great day and good night.